Hello and welcome back. We're on part 4. We're almost done. So we're going to continue on talking about behavior and somatic functions. And mental disorders of behavior and somatic is PTSD, ED, OCD, ADHD, and substance use. Some people who have experienced major trauma such as war, torture, hurricanes, earthquakes, accidents, or personal violence continue to feel terror long after the event is over. They may experience nightmares or flashbacks for years. The flashbacks are often brought about by triggers related to the experience. PTSD is different than an acute response. Anyone who experiences such events will be stressed out or have a severe stress response. However, for most people, the symptoms will abate or go away over time. PST can be thought of as a failure of the acute stress response to resolve. Everyone has an acute stress response to events that are acutely stressful, and it gets better over time and generally resolves after 6 to 10 weeks. In PTSD, the curve does not decline or go away. It continues. Encouraging debriefing of a traumatic event can increase PTSD. We do not want to re-traumatize and increase likelihood of PTSD. Our brains are doing their best job. For survival and thriving, we want to remember cognitively about threats, but not emotionally. Emotion drives memory into long-term memory storage. Our brain needs to develop cognitive remembering from emotional remembering. PTSD has both components and is when our brain fails to decouple the cognitive memory from the emotional memory. Traumatic events and the school setting. What not to do. Don't do something, do the right thing. Usual approaches that may not be helpful include critical incident stress debriefing, critical incident stress management. Don't call in outside grief specialists. Don't create visual memorials that are in central locations. Do not bring in outside therapists or supports unless you are overwhelmed. Students should turn to those that they already know as a first step. This goes back to our very beginning of part 1, is to looking at those internal supports within your school before looking for external. And again, it's looking for those external supports when the internal ones become overwhelmed. So what to do? Stress symptoms immediately following a traumatic event are interventions such as normal and do not require outside grief or crisis counselors. Information about what is expected and normal should be provided to students, parents, and staff. Provide clear leadership and information about the event and what will be done next. Have a plan. Some interventions, such as the critical incident debriefing and management, may not be helpful and may even be harmful. Following a traumatic event, schools could provide quiet spaces with staff support after hours and identification of symptomatic youth 4 to 6 weeks after the event. Remember the teachers. Identify symptomatic individuals 6 weeks or so after the event. Symptomatic students can be offered cognitive behavior therapy or other evidence-based psychological interventions by trained professionals. This is not grief counseling. Avoid the pressure to do something and focus on doing the right thing. Project Aware recommends that schools interested in crisis response and incident response examine the PREPARE program. The Prepare curriculum has been developed by the National Association of School Psychologists. Prepare training is ideal for schools committed to improving and strengthening their school safety and crisis management plans and emergency response. Usual approaches that we thought were helpful may not be. Eating disorders. Eating disorders are the most physically dangerous of mental illnesses. Anorexia nervosa, severe weight loss, starvation, is the one mental health disorder that leads directly to death through starvation. Others may lead to suicide. Bulimia nervosa, binge and purge food behaviors. Do not bring people who are first-hand speakers on bulimia or self-harming. This is not an effective intervention and may have the opposite effect. Remember that anorexia and bulimia have potential social contagion effect. What to know about treatment? It usually requires a specialty mental health services. Psychological treatments are considered to be first-line treatments. Medications can be helpful in bulimia, but not usually anorexia. Treatment usually takes 12 weeks or more for substantial improvement. Hospitalization may be needed if the disorder is severe. Secrecy and avoidance of treatment recommendations are common. If you notice self-harming behaviors, communicate your observations to the treatment team. It is recommended that youth suspected of having an eating disorder are directly linked to a specialist or counselor. What to do? Remember that eating disorders can be difficult to treat and may require intensive and long-term interventions. So what to do is to raise concerns about the health of a student, inform them that help is available, refer to a healthcare provider, and do not become involved in a power struggle over food or preaching about healthy eating. Obsessive compulsive disorder. Obsessive compulsive disorder. This disorder involves intrusive, unwanted thoughts or obsessions, the performance of elaborate rituals, compulsions, in an attempt to control or banish the persistent thoughts or to avoid feelings of unease. The rituals are usually time-consuming and seriously interfere with everyday life. For example, people may be constantly driven to wash their hands or continually return home and check the door to see if it's locked, or an oven to see if it's turned off. People with this disorder are often acutely embarrassed and keep it a secret, even from their families. What to do? Provide information of what you think the problem is to the student and inform them that there's an effective help for their concern. OCD is best treated in combination of cognitive behavior therapy and SSRI type medication. It requires specialty mental illness care, 12 weeks for symptom reduction. Attention deficit disorder is the most commonly diagnosed behavioral disorder of childhood. In any 6-month period, ADHD affects an estimated 4 to 6% of young people between the ages of 9 and 17. Boys are 2 to 3 times more likely than girls to develop ADHD. Although ADHD is usually associated with children, the disorder can persist into adulthood. Children and adults with ADHD are easily distracted by sights and sounds and other features of their environment, cannot concentrate for long periods of time, are restless and impulsive, or have a tendency to daydream and be slow to complete tasks. The 3 predominant symptoms of ADHD are 1, inability to regulate activity level, hyperactivity. 2, inability to attend to tasks, inattention. And 3, impulsivity or inability to inhibit behavior. Common symptoms include varying degrees of the following: poor concentration and brief attention span, increased activity, always on the go, impulsive, doesn't stop to think, social and relationship problems, fearless and takes undue risks, poor coordination, sleep problems, normal or high intelligent but underperform at school. ADHD is a neurodevelopmental disorder, which means that it's a disorder caused by problems in the growth or development of the brain. This is why some children may grow out of ADHD. Their brain growth and development improves. What causes these problems? From what we understand today, ADHD has an important genetic component. It tends to run in families, which means the immediate family members of someone with ADHD are more likely to also have ADHD than the general population. Environmental factors may also play a role. A particular concern are those that impact brain growth and development in the womb, during birth, or in early childhood. A person's environment can also influence the extent to which ADHD causes problems in his or her life. ADHD is diagnosed more often in boys than girls. Girls with ADHD are more likely to have difficulty paying attention, but they often don't demonstrate as much hyperactivity as boys. Girls who have trouble paying attention often daydream, whereas inattentive boys are more likely to move around constantly or fiddle aimlessly. What do we know about treatment? Psychostimulants may work quickly, within a few weeks, whereas other meds like Strattera may take up to 2 to 4 weeks. So it can be effectively treated in primary care. School participation and assessment is often very helpful, and medications, as I mentioned, are very useful. Treatment response usually is evident within a week, and the degree of misinformation and disinformation about ADHD and its treatment. Learn the right information. Provide to the student and parent if asked. Effective treatments improve outcomes. When they are maintained, some students will improve with age and their brains mature, and there's a decrease risk for substance abuse. So what to do? Participate in the assessment and treatment protocols with healthcare providers. Provide access to useful information about ADHD and its treatments. Encourage and strength-based intervention approaches. Be aware of the impact of ADHD and the psychological functioning of the student. Always assess for the presence of a learning disability. And you can use the family liaison with that connection to family. As we learned in the beginning, the more that we are aware and know about the condition, the more we are informed in our treatment options. Teens and drugs. Language matters. When we talk about medicine, use the word medicine. Don't call Tylenol drugs or reinforce the conflation of medicine and drugs. When talking about drugs, use the word drugs. Not the continuum here. Addiction or dependence takes time to develop. Most youth are experimenting or misusing, abusing substances versus having a full-blown addiction. What is addiction? We can use the ABCs of addiction to decipher what addiction is. People are most likely to begin abusing drugs, using tobacco, alcohol, and illegal and prescription drugs during adolescence and young adulthood. By the time they are seniors, almost 70% of high school students will have tried alcohol. Half will have taken an illegal drug. Nearly 40% will have smoked a cigarette, and more than 20% will have used prescription drugs for a non-medical purpose. There are many reasons adolescents use these substances, including the desire for new experiences, an attempt to deal with the problems or perform better in school, and simple peer pressure. Adolescents are biologically wired to seek out new experiences and take risks, as well as to carve out their own identity. Trying drugs may fulfill all of these normal developmental drives, but in an unhealthy way that can have very serious short and long-term consequences. Most teens do not escalate from trying drugs to developing an addiction or other substance use disorders. So when we look at the criteria for drug addictions, A, there's abuse of intended use or non-therapeutic purposes. B, dysfunctional behavior, presence of typical drug-seeking behaviors, neglect of responsibility, use despite negative personal, vocational, and legal consequences, and C, for craving induced by the substances. Understanding withdrawal. Symptoms are like a spring. You can put a treatment on the spring to dampen the symptoms. Remove the treatment and the spring may return to its original shape, relapse. If the symptoms comes back worse than before after treatment is removed, it is a rebound. Withdrawal is when a substance is removed from the brain. What this looks like in school. The high produced by drugs represents a flooding of the brain's reward circuits with much more dopamine than natural rewards generate. This creates an especially strong drive to repeat the experience. Despite popular belief, willpower alone is often insufficient to overcome an addiction. Drug use has compromised the very parts of the brain that makes it possible to say no. Not all young people are equally at risk for developing addiction. Various factors, including inherited genetic predispositions and adverse experiences in early life, make trying drugs and developing substance use disorder more likely. Approximately 10.3% of young people have a substance use addiction. Adolescent alcohol and substance use screen. The CRAFT is a clinical screening tool for care providers, however, could be used by school counselors or other educational staff to screen substance abuse. So CRAFT is, have you ever, using this criteria, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? R, do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? A, do you ever use alcohol or drugs while you are by yourself, alone? F, do you ever forget things you did while using alcohol or drugs? F, do your family or friends ever tell you that you should cut down on your drinking or drug use? T, have you ever gotten into trouble while you were using alcohol or drugs? What do we know about treatment? Early identification, the better. Alcoholism is to sustain treatment an average of 8 sustained treatment interventions. If concurrent disorder exists, treat both at the same time. Many teenagers who have a substance use disorder can also have one or more psychiatric disorders. What are treatments expected to do? We focus on recovery. We treat disorders like chronic health disorders. We manage the disease, like diabetes. We improve the symptoms that a person is suffering from, improve the person's ability to function at home, work, and with friends, and stop the disorder from coming back. How to think about treatment? Use best evidence. Scientifically demonstrated treatments for disorders are treatments that have been tested to be effective and safe. They are specific. We call these types of treatment evidence-based. They are approved by legitimate organizations and meet standard of quality and criteria. These are the standard. Complementary treatments may help. Specific treatments work better, but are not effective on their own to treat disorders. Exercise, vitamin D, omega-3 are examples. Alternative treatments, interventions that do not have evidence or research to prove effectiveness. Evidence has different types of quality. When considering an intervention or treatment to use with youth for mental health, suicide, behavior, or anything else, consider the quality of the evidence. A randomized control trial, an RCT, is the best quality of evidence. Think of the various types of evidence as a deck of cards. The higher quality research, like a higher card, trumps all other research. The findings from one RCT can trump 8 case studies because the evidence is so much higher. Treatment purpose and recovery. Treatments are established as standard by legitimate organization at national and international levels. Specific treatments can control symptoms, stop symptoms from coming back, promote recovery to function as well as possible. Complementary treatments such as exercise, good sleep, etc., do not meet threshold for specific treatment. They may help, but they are not the sole solution. Use complementary treatments to supplement specific treatments. What is good for the body is good for the brain. Time of treatment, effective response. Note the red line. Seeing the progression of how someone may experience a depressive episode. Often someone will begin to feel better, even without treatment, and they may attribute their improvement to something random like their changed breakfast cereal. Now note the blue line, showing the progression of someone who was treated for their depression. See how they did not experience the lowest of moods, as was the case without treatment. The difference between the lines is referred to as the positive treatment effect. Helping. Getting well, stay well, keep well. All helping interventions act on the brain and assist in one or more functions of the brain. Psychological, counseling-specific psychotherapies and the common effects, somatic, medications and others, social, groups, communities, etc. And you can learn how to ask about your treatment and using evidence-based medicine. And you can find this guide here that on the slide at teenmentalhealth.org. There are so many resources on that website. I really encourage you to visit it. How to think about treatments and realistic considerations. Note that treatments take time for effects to be felt, and that there needs to be careful monitoring and tweaking to find the right medication and dose. Also, just like other types of treatments for health concern, there are some illnesses that respond better and some more chronic or severe cases with less positive response to treatments. Not all people respond the same way to any given treatment. All treatments have the potential for side effects. All treatments are applied in the context of possible expected placebo and nocebo responses. Many treatments for mental disorders have a delayed time of onset, and it can be worse sometimes before they can feel better. Treatments for mental disorders have similar success rates as those for physical illness. Cannot yet predict response, so trial and error may occur. That concludes part 4. Part 5 is a short one, and we will be back soon.